This is the MyHeart.net podcast. This show is produced by Dr. Philip Johnson in conjunction with VitalEngine.com. Please welcome your host, Dr. Alain Bouchard, cardiologist at UAB St. Vincent's.
So, welcome to MyHeart.net, and today's episode is about when obesity becomes a disease. We know that more than 40% of the U.S. adults are living with obesity, and the rates are rising in children and teens. But here's the big question. When does weight gain cross the line into being a disease? And today we're joined by Dr. Tim Garvey, an expert in obesity medicine, to unpack really the science, the risk, and the future of treatment. Dr. Tim Garvey is Associate Director, Professor in the Department of Nutrition Science at the School of Health Professions. He's a senior scientist at the UAB Nutrition, Obesity, and Research Center, and he's very involved with the Lancet Diabetes and Endocrinology Commission. And they've just published, in January 2025 in the Lancet, the definition and diagnostic criteria of clinical obesity. So, Tim, thank you for taking the time and trying to enlighten us about obesity as a disease.
Well, Alan, thank you for this invitation. I'm happy to be here and to speak with you and your audience about this really important subject. And you've outlined the challenges that are facing us in terms of how we approach this disease very well. So I look forward to our conversation.
Thanks, Tim. Before we dive into the clinical side, though, can I ask you, how do your patients usually feel when they first hear the word obesity used in a medical context?
It varies, Alan, but we really have to be on our guard here because our patients have been stigmatized by social media and stigmatized by their contacts and engagement by our healthcare system in many instances. And that's where this term obesity is used. So it can have negative connotations when it feeds into this bias and stigmatization, which patients internalize weight bias, and that can have that can impair our therapy in terms of the confidence that patients have that the therapy will work. They blame themselves. They sometimes don't think they need help and it's their fault and they don't want to get therapy. So we have to be careful of internalized weight bias and use terms like, weight. I want to talk to you about your weight and the implications that has on your health. Kind of lead in like that. And so I try to avoid the word obesity whenever I can.
I think it's good advice. But we know the numbers are striking. I mean, in 2025, we have about 40% of the world population with overweight and obesity. And it's predicted in 2035 to rise to 51% of the population. That's about 4 billion people. Amazing. And in children and teens, the rise is even faster. In 1975, if we count that there was maybe 1% of the children and teens that had a problem with overweight and obesity, today, in 25, it's about 10%, and it's predicted to be 20% in 2035, just in 10 years from now. So, why are we seeing such a dramatic rise in obesity over the last few decades, Tim?
Well, Alan, we have the same genes that we've always had, the same genes, and which changes our environment. And we know this disease really arises through an interaction between environmental cues like, our cultural and personal preferences for diet and physical activity, the built environment, and these interact with a large subset of susceptibility genes. Hundreds of these have been identified, and we all inherit different subsets of these genes. And those of us who inherit greater numbers of these genes are more likely to get obesity, excess body weight, in any given environment. So it's really a changing environment, and the statistics that you quoted are alarming. Something impresses me is a statistic that if you have excess adiposity, and I'll use that term instead of obesity, or else I'll use adiposity-based chronic disease. If you have excess adiposity in childhood, that cuts 10 years off your lifespan. And that can be worse than cancer, but we don't think about it in those terms. And it's really, we're really going to have a problem. And it's it's going to require the concerted action, not only of our healthcare professions, but, the regulatory agencies, our healthcare systems and governments. We're really going to need to kind of work on this problem, as you know.
Yeah. Yeah. Are there any differences in adiposity rates or obesity rates between men and women or across different ethnic groups, Tim?
Yes, that's true. In many, it varies a little bit by ethnicity, but some of our ethnicities that have highest rates of obesity, like African Americans and Hispanic Americans, it's the women that tend to have more obesity. Native Americans, it's a little bit more equal. Men can have plenty of obesity too. But you go around the world, and this is not a United States problem. This is a worldwide problem. And you're right, it does vary by region and ethnicity, but both sexes have a problem here.
We know there's some limitations to use the term BMI. I mean, so why is there circumference, I'm sorry, or waist to hip ratios that are better, and what do they mean clinically in terms of health risk?
Well, this disease requires both an anthropometric component to the diagnosis. By anthropometric, I mean, your body, physical shape of your body and weight, and also a clinical component, which is really examining the patient for obesity-related complications and related diseases. So when we talk about the anthropometric component, we use BMI. I mean, that's just ingrained. So our electronic medical records calculate that for us. And it's been used for decades in epidemiology and other kind of publications. But remember, it's height and weight. It's not a direct measure of fat mass or adiposity. It does have some correlation with cardiometabolic disease outcomes. But I think what's emerging as a preferred anthropometric measure is waist to height ratio, not waist to hip, but waist to height ratio, which is more highly correlated with cardiometabolic disease outcomes than any other kind of simple anthropometric measure we have, more so than BMI. And it's not something you have to adjust based on sex or ethnicity. In Asians, a lower BMI qualifies you for obesity, this diagnosis of obesity, because it's associated with higher risk. But if you use waist to height ratio, then that's the same for everybody. And the cutoff there is usually 0.5, or sometimes it's 0.53. But at any rate, if you're above that, that's portends good health. If you're below that, that's a significant cardiometabolic disease risk factor. So we're not going to get rid of BMI, but it's important to realize that doesn't always tell you exactly how much adipose tissue somebody has. If a teaching slide, I have, I use this teaching slide where I have on one side, I have, Conan the Barbarian, and he's got, muscles rippling all over the place. And on the other side of this slide, I have this guy in a Speedo swimsuit at the beach with a very big beer belly, if you will. And they both have the same BMI. So I use that just for illustration. So sometimes we have to make sure that when we get a high BMI, we have to make sure that is indicative of increased adipose tissue mass. And usually we can do that through simple inspection or examination. But, many societies are calling for, more precise measurements of adiposity using DEXA scans and so I don't know, but I think for the most part, BMI works okay as long as we examine the patient.
Right. And I guess we're wanting to measure this visceral or central obesity, which seems to me more damaging than the one you just find, under your muscle, under your triceps, for example.
Yeah, exactly. And waist to height does, of course, it's waist measurements in there too. So it does incorporate, abdominal adiposity, which really is the bad news for cardiometabolic disease type outcomes.
Tim, would you mind giving us some examples of how obesity affects different systems like the heart, the lung, or the liver? And at what point does this become what you call clinical obesity?
Yeah, I think you're referring to the Lancet Commission on Obesity that was recently published. You mentioned that. Um, they just differentiated between preclinical obesity and clinical obesity. And what does that mean? Well, preclinical obesity, you have excess adiposity, but no complications or related diseases. Okay, you're otherwise healthy except for having excess adiposity. You're certainly at risk of developing complications, and that needs to be taken into account. And treatment is warranted because of that increased risk. But the commission kind of looked at it more as a risk factor, not but still requiring treatment. And then they differentiate that with clinical obesity and identified a number of pathophysiological processes that are there just because of the excess adiposity, nothing else. It's integral to the state of excess adiposity. And I think this is a strong statement that obesity is a disease. If you have, and I'll mention some of these, the triumvirate of increased high fasting glucoses, high triglycerides, and low HDL. Now we recognize that as kind of the metabolic syndrome, and it places patients at higher risk of diabetes and heart disease. But that's felt to be integral to adiposity, to increased adiposity itself. Also, osteoarthritis would be another example. Increased body weight, damaging the joints, obstructive sleep apnea, and hypoventilation, making it, increased mass in the chest wall, kind of making it more difficult to breathe, and increased fat mass in the neck and upper thorax, precipitating obstructive sleep apnea. Another example might be MASLD, metabolic associated let's see, what does MASLD stand for? Metabolic associated fatty liver. Okay,
Right.
fatty liver is part of obesity, but going on to MASH, steatohepatitis with inflammation and fibrosis, that requires some other predisposition to this fat in the liver that increases the tendency towards fibrosis, and there's genes identified for that. So these things integral to increased adiposity. And then you have obesity-related diseases where you have increased adiposity, and you can have complications, but you require something else that's not part of obesity per se to get that. An example might be diabetes, because yes, the insulin resistance of increased adiposity, you need that, but you also need impaired insulin secretion to develop hyperglycemia. So that's something else. Or I mentioned the example of MASH. So I think the commission gave meaning to these terms. Comorbidities are just two things that go together by chance that aren't related. Complications are something that are integral to the state of adiposity, increased adiposity, and obesity-related diseases are these complications where you need obesity and then it interacts pathophysiologically with some other process to produce disease. So that's all kind of complicated. And what does that mean in terms of patients and when we see patients in our clinic? This idea is preclinical obesity a disease or not? I think that's where a lot of the confusion lies. But this has been recognized by many professional societies. The American Association of Clinical Endocrinologists recognized with stage 1 obesity is increased adiposity without complications. And the European Association for the Study of Obesity has recognized this as the same entity. So it's part of the evolution of the disease state, I believe. So, you know, to me, it's not worth arguing whether preclinical obesity is a disease or not. It's part of the overall complex that we call adiposity-based chronic disease, which incorporates all stages of the disease, and we need to tailor our therapy to where patients are on this spectrum, and perhaps be more aggressive with those who are sicker, if you will, that have complications and related diseases, who can most benefit by that therapy. And doing that, we increase the benefit risk ratio and the cost effectiveness too of therapy. So I think that's the kind of general idea that I believe that I keep in mind and clinicians should keep in mind. But by no means does it mean that state of increased adiposity by itself is not a disease in my mind, and it requires appropriate therapy.
It seems like in the preclinical state of obesity, there should be a great opportunity for prevention. I mean, we can see how obesity is not only is related to heart disease, but also to multiple cancers. And I'm thinking for women, like breast cancer
Yeah.
and different types of cancer. I think there would be kind of a great opportunity, for us physicians to really kind of focus on prevention.
I couldn't agree with you more. If primary prevention would be keeping people from getting increased adiposity in the first place, but with preclinical obesity or stage one obesity, obesity without complications, we're really in a secondary prevention mode where we want to prevent further weight gain and we want to prevent the emergence of these complications, which I categorize as, cardiometabolic. And so patients are increased risk, they have accelerated atherosclerosis, so they're at increased risk of coronary artery disease and stroke, congestive heart failure, MASH, diabetes, and this is exacerbating their hypertension and dyslipidemia. And then you have the biomechanical complications, which are due to increased body weight. And I mentioned obstructive sleep apnea, um, uh, 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 GERD would be another example, urinary stress incontinence, as well as osteoarthritis.
Yeah. Well, let's finish by discussing maybe a clinical case. Here's Bob. He's 50
Okay.
years old, and he comes to see us. He weighs about 250 pounds, and he's got a BMI of about 36. So, and he works in a company as a desk job, working on a computer. He sees his general practitioner for knee pain. And of course, he gets referred, to an orthopedic surgeon for evaluation. And when he mentions that he's also depressed, he's feeling low, he's told to find a psychiatrist elsewhere. It seems to me that how if we define obesity as a disease, I mean, it seems like this would be kind of a good way to really kind of put our act together to help not only public health policy, treatment strategies, and as you discussed at the beginning, maybe reducing stigma, and really help these patients better and considering our patient as a whole and not practicing as, in silos. And I treat only, heart disease, and someone treats only the joints, someone treats only the diabetes, and so forth. What do you think, Tim?
Well, of course, and that osteopedic surgeon that's seeing that patient is going to evaluate the patient for perhaps a knee transplant. And of course, our orthopedic surgeon colleagues are sometimes even reluctant to perform a surgery like that if the BMI is too high. But we know, and many of our orthopedic colleagues know as well, that weight loss can improve symptomatology, prevent the need for a knee transplant, or else bring people into a BMI range where the knee transplant can be done more safely and with better outcomes. So, um, there's a good example of where we need maybe a team approach if that doctor is not used to using some of the second generation obesity medicines, a referral for let's get some weight loss. Let's work together with the orthopedic surgeon, see what we can accomplish in terms of loss of weight and improve symptomatology. There's phase 3 trials showing that some of these GLP-1 receptor agonists can improve osteoarthritis. So that'd be a perfect example of the need for teamwork. But I think it's in cardiometabolic disease where we need to really work on this, Alan, because let's say you have a patient with metabolic syndrome, for example, or prediabetes. We know that patient is at risk of developing heart disease, heart failure, chronic kidney disease, diabetes, MASH. And so the primary care physician has to recognize all of these risks and initiate therapy with these risks in mind. And then when some of these complications develop, of course, they have to be ready to refer and have a comfortable threshold for when they refer for these specific complications, but then need to work with some of the subspecialists to improve outcomes. And these second generation obesity medicines have been shown to treat and prevent all of these complications that I just mentioned. They really become kind of cardiometabolic disease medications, is the way I look at it. for treatment and prevention of all of those complications. So I think that's where the interaction between primary care and subspecialty medicine is really, we need to work through patterns of referral and care in those instances.
I see around the country cardiometabolic clinics popping up, having maybe 4 or 5 different specialties, kind of working together, seeing patients and referring. Maybe those will develop, even more particularly. And then maybe there should be an arm of clinical trials, as part of these cardiometabolic study to help, our patients enroll in different studies, because a lot of these medications, they're expensive, they're not approved, by the insurance, and they cost a fortune. Patients can't afford it. So maybe that could be a nice way to really get our patients in clinical trials and provide them with an opportunity and maybe to benefit from some of these future drugs.
Clinical trials are great. I conduct a number of those, but then when the trial's finished,
Yeah.
then what do we do with the patient? I mean,
Mhm.
I think, we're more and more we are able to get approvals. It's still, we've got a long way to go. And it's difficult for the patient and the doctor with the pre-authorizations and finding, which insurance will cover what and which pharmacy might have the drug available. And it just, it adds such a logistical burden.
Yeah.
I think
Layer.
that some of the lethargy in terms of treating these diseases as they should be in an evidence-based way. And we just have to work through that. I mean, now liraglutide has become generic, and it will come to the pharmacies at some point. Um, I don't advocate for these compounded GLP-1 products. We don't know what's in there. They're now really illegal, not that they're not available.
In several states, I think.
Yeah. And I'm not even a fan of obtaining these medicines online prescriptions if the patient doesn't have an evaluation.
Yeah.
I mean, then how do you engage in complication-centric care if you don't examine the patient or assess the patient for what complications they may have?
Yeah.
So that's really, from the medical perspective, our endpoint of therapy is to treat and prevent these complications that are responsible for impaired quality of life and confer morbidity and mortality. And of course, we work together with the patient so they understand how their weight problem, interacts with these complications. And we also take into account what the patient wants. Okay, we have to meet the patient where the patient is, and they may just be interested in losing X amount of pounds, and we'll try to make them happy, but at the same time achieving sufficient weight to treat and prevent these complications, and making the patient aware of the health benefits that are there, and then the real benefits of our medical intervention.
Yeah. Well, Tim, thank you again for helping us, see obesity through your medical lens. It's clear that understanding when weight gain becomes a disease, they can change the way we can prevent, treat, and talk about it, with our patients.
One just closing comment, Alan, if I may.
Yeah.
This diagnostic term, adiposity-based chronic disease, has been endorsed by the American Association of Clinical Endocrinologists and the European Association for the Study of Obesity. And I think when you use patients aren't going to use that term necessarily, but as a diagnostic entity, it tells you what we're treating. Abnormalities in the mass, distribution, and function of adipose tissue, and why we're treating it. It's a chronic disease. What do we do with chronic diseases? They have complications, and that's what we try to prevent. And that's the goal of therapy, to treat and prevent those complications that really impair the patient's health. And when you use a term like that, it kind of entrains or engenders a complication-centric approach to care. So we don't forget about why we're really treating this disease and what the endpoints of therapy are. So at least conceptually, if clinicians kept that in their mind, that this is another diagnostic term for this disease and what the implications are.
Yeah. Tim Garvey, the expert, in obesity and diabetes. And I want to thank you very much. You're kind of a great representative and leader in the field at the University of Alabama in Birmingham. Thank you very much, Tim. Very
Okay,
great.
thank you, Alan. I feel the same way about you, by the way, in terms of what you bring to the clinic. So thank you again for inviting me.
Thank you so much. Have a great weekend.
To learn more from our team of cardiologists, please visit us at MyHeart.net. You can also follow us on social media by searching MyHeart.net on Facebook and Twitter. And be sure to subscribe to this podcast so you don't miss our next episode.